Alfaisal. Okay. Yeah, I'll be talking about the spinal cord and its lesions today. If you guys can hear me, and if it's clear, I'll just proceed. And if it's not, let me know, okay? So I'll take this as a sign that it's clear because no one said anything, okay? Should we start? Okay, Halas, thank you. By the way, if anyone has any questions during the lecture, you guys can just unmute yourself. I think you guys have the ability or not. If you have given them the option, yeah, give them the option. If they have any questions, they can unmute yourselves because it'd be difficult for me to see the chat because I'm going to be on the lecture side. So yeah, just try to mute yourselves if you guys have any questions, okay? So I have about 45 minutes or an hour to talk about spinal nerves and spinal cord. So I saw Dr. Yaqeen gave this lecture in 4 parts. I don't know why, it's not that extensive. Inshallah, it'll be very simple after I break it down for you guys. So you're going to see I'm not going to, in this lecture is like 73 slides. I'm just going to talk about 10, 15 slides in this lecture, okay? Because I'm not going to discuss the spinal cord and C8s and the vertebra and everything. This is stuff you guys should know by now. You'll go over it yourselves, and there's not much for me to explain in these things. The main thing is the, three cords themselves, the 3 columns, and then the lesions themselves. So that's the thing I'm going to be going over. The main 3 columns and then the lesions. I'm not going to touch on the other columns and other things because I know that none of the questions are going to come in the exam from that. And one thing you have to know about Dr. Yaqeen is very focused on all the clinical anatomy, okay? So he's going to give you all the questions are going to come from lesions, and basically, because if you understand, if you know the lesions, that means you know the normal anatomy, okay? So that's what you should focus on too. All the extra stuff that's going to, maybe you get one question from here, like this, this slide, like add something, or it's rarely. But most of the questions are going to come from the lesions and from the columns, okay? So that's why I'm going to discuss that and spend most of my time with that, because other stuff is very basic, and the other stuff you guys can, understand, just like structure of nerves and stuff. I'm not going to spend time on this at all. So I'm just going to go down all the way to where the spinal cord starts and discuss it. So this is a very good picture. You can, this differentiates, and this can tell us the difference between the different sections of the spinal cord. I'd tell you guys to have an idea of this because they might be missing your OSCE or whatever, right? It's very simple. So you can see the cervical, the thoracic, and the lumbar and the sacral ones, okay? So in the middle, you have the gray matter, and on the outside, you have the white matter. Okay, why is it called gray matter? Is because you have the cell bodies there, okay? So they accumulate, they make it gray, and on the outside, you have nerves and everything, so they make it white, okay? One thing I'd tell you to, so make easy, the easy way for you to remember the difference is the sacral one. It's a lot of gray matter. In the cervical one, a lot of white matter. So you already know the cervical and the sacral. In the thoracic one, if you can, I'll zoom in, you can see this thing on the side. There's a mark on the side. There's like a edge thing coming out, okay? This is basically for the, there's a lateral horn, okay? That's only in this thoracic part, you see it. And this is because of the sympathetic nerves. So sympathetic nerves come out of the thoracic, and you see the lateral horns in here. So you won't see it in cervical, you won't see it in lumbar, you won't see it in sacral. It's only in the thoracic. So that's a very good way of differentiating between the other ones. And the only thing that's remaining is lumbar. So sacral has the most gray matter, the cervical most white matter. Thoracic has the lateral horns, so the only thing that remains is lumbar. So yeah, that's basically how I remember stuff. Yeah, it's very good to just get used to and remembering stuff by just your own type of mnemonic or whatever you want to call it. All right. Let me go down to the picture. That's actually good. Yeah. Okay. So now we're going into what the spinal cord looks like. Okay, so as I said, the middle part is the gray matter here. All of this is butterfly part. Now on the side, you have the white matter, okay? So what we're going to discuss is the gray matter first, and then we're going to go into the white matter part, okay? At the back here, I wish I could draw. I think I can draw, but let me see. Let me get my pen. But okay, in the back, when you guys see, 1 second, let me just pick the pen. If it will let me draw. Okay, khalas, we're not going to draw, but you can see with my cursor anyways. So at the back over here, and they have a sign too, sorry, it labeled it. So at the back, you have the posterior horn over here, okay? So it's divided, so the gray matter is divided into 3 parts, okay? We'll divide it into 3 parts. You have the posterior horn, you have the interior horn, and you have the lateral horn, okay? Posterior horn is all your sensory things are going to be there, okay? It's all for your senses, okay? Anterior horn is going to be basically all for your motor supply, okay? And the lateral horn is basically just sympathetic. And as I said, the lateral horn, you're not going to see it anywhere except in the thoracic. That's why it says here T1 to L2 and L3, okay? So very simple. There's nothing too much to talk about here. It's basically you have your posterior horn, your anterior horn, and your lateral horn. Posterior horn, again, just your sensory for your senses, and basically anterior horn is for your motor supply, and this is for your sympathetic supply, okay? Now on the outside over here, you have the white matter, okay? In the back, you'll have the dorsal column, okay? The dorsal column is going to be basically for your pressure, your vibration, your fine touch, and you have your proprioception in the dorsal column, okay? Over here, and then you have your lateral column. So basically you have your spinothalamic tract, okay, which is going to be on this side. So in the front, kind of in the front side, you have the spinothalamic tract, okay. The spinothalamic tract is basically pain and temperature, okay. Spinothalamic tract is over here. You have your pain and temperature. In the back, you have your dorsal column. Again, both of these are sensory, okay. So this is just pressure, vibration, pain, temperature, and the other one, this one's also proprioception, okay. And the tract over here, which is also basically on this side, is the motor tract. Okay, you have the corticospinal tract, and this is your tract for basically motor supply. Okay, your voluntary motions and everything. Okay. There's now what you want to understand is that and we're going to talk more about it when we go into the breakdown. I think the slides are there of how the tracts and everything form. But main thing right now, I want you to know is that the division in the spinal cord. Okay, so I'll do it again so you guys know. You have your white matter, you have your gray matter. Okay, in gray matter, you have your dorsal horn, posterior horn. You have your anterior horn, ventral horn. Anterior horn, motor supply. Posterior horn, your sensory, and your lateral horn is basically your sympathetic, okay? In your white matter, you have your dorsal column. Again, it's sensory, and it's basically for your pain, your pressure, your vibration, fine touch, and proprioception. You have your spinothalamic tract, which is, again, basically pain and temperature, okay? And it's also crude touch and pressure as well, okay? And then you have your corticospinal tract, okay? This is basically voluntary motion, okay? This is the main thing I want you to understand from this slide right now, okay? And we go down to the tracts now, okay? Because there's not much in the gray matter for me to explain and break it down to you. If anyone has questions, again, if I'm going too fast right now, for you guys, please let me know, because this is just a quick review and I want you to just understand it so you can get the questions right and you can understand the lesions from it. That's all you need to know. You don't need to know and go depth into all these things and what track is retrospinal or blah, blah, blah. These are not going to come in your exam. They're going to come in your boards also in your steps. It's just going to be simple. What's the gray matter, what's the white matter, and the different tracks, okay? So here you can see a picture of the spinothalamic tract and how it's basically how it goes. Okay, so understand one thing: the sensory tracts, they have three neurons. Okay, it's going to be three different parts of it. Okay, while the motor is going to be two. So so spinal is 3, motor is 2. Okay, so the spinal one, the first one, we're going to talk about the spinothalamic tract, which has pain, temperature, and crude touch. Okay, so the first neuron is coming from here. So this one, this is your dorsal root ganglion. It's going to go from here. It's going to sense whatever it's going to sense, right? And it goes from the spinal root, and it's going to go from here to the spinal root. Okay. It senses whatever, senses any sensation, pain, temperature, crude touch, whatever, and then it goes from the spinal root to the cord. Okay, and then so it's going to go from here to here. Okay, this one right here, and then it decreases. Okay, it goes from one side to the other. This is a very important point you have to understand, that the spinothalamic part or the spinothalamic tract, it goes from one side to the other side. Okay, at the level of the spinal cord, not above. So spinothalamic tract is the only one that at the level of the spinal cord, it is actually changing sides. Okay. So the first one here to here, spinal root to spinal cord. Then then it changes sides, and then it goes all the way over here, all the way to the thalamus. Sorry, and it goes all the way. So from here all the way to the thalamus. Okay, and then from the thalamus it will go to it goes in the thalamus. It goes something called the VPL, and then from the VPL it goes to the cortex. So the VPL to the cortex is very common. It's the same thing that happens in the other sensory tract also. So yeah, that's the main thing. Again, I really understand this is a very quick explanation, a very quick breakdown, but this is genuinely all you need from the whole lecture. And I know that in second year, when I was also with you guys at your level, it was like a very long and a very difficult thing. But then I saw it yesterday and the other day, I just went over. It's a very small 30-minute explanation. It's not very in depth, like it doesn't need 70 slides. So again, I'll do it again so you just understand, so that you have So you have three neurons, okay? One of them is going to go from the spinal root and it's going to go to the spinal cord, okay? And from the spinal cord, it's going to switch sides and it's going to go at the level of the spinal cord, it's going to switch sides. And then it's going to go all the way up to the VPL of the thalamus. And from the thalamus, it goes to the cortex, okay? So what this means is if there's any lesion, okay? If there's any lesion, okay? Any point, it's going to be, let's say there's a lesion at the, at any level, it's going to be on the contralateral side, okay? Except if it's the lesion at the specific point. So if it's at the lesion at the spinal cord level, it's at the exact level, it's going to be ipsilateral. But if it's anything above it, it's usually going to be, or below it, it's going to be on the contralateral side, okay? Because it's switching over, that's why. The posterior column, which is the next one, is the dorsal column or the medial meniscus column, whatever you want to call it. Okay, so what it does is basically, again, the first neuron is going to come from the spinal root up to the cord. Okay, and it's going to collect this information from the posterior corpuscle and the myoclonic corpuscle. Okay, and these are the ones for the pressure and the vibration and whatnot. And you collect these the information from here, and then it goes all the way. From here, we'll go straight up all the way to the VPL, but it crosses at the lower medulla. Okay, so what it does is, so it takes information from here, goes all the way to the lower medulla, it changes sides, and then goes all the way to the VPL, and then from the VPL it goes to the cortex. And you have two nuclei. You have the nucleus gracilis and you have the nucleus cuneatus. Okay, so it's very easy to remember. A quick method of remembering is that gracilis, because it has an L here, it's for the lower body. Cuneatus, because it's a U, as for the upper body. Okay, it's taking information for the upper body, cuneatus, and the gracilis is taking information for the lower body. I hope that makes sense. So again, I'll repeat that again, is that you have information coming from the spinal root all the way is going to go to the cord. From the cord, it's going to go all the way up, switches at the lower medulla, and then straight goes up all the way to the VPL of the thalamus, and then from there it goes to the cortex, okay? And it gives you vibration, proprioception, and fine touch. I hope it's clear up till here. I really hope I'm not going that fast. If there's any question. Okay, let's see, there's a question to chat. For the spinothalamic occlusion above the decussation equals contract. I don't know if this is a question or not. Okay, wait, someone said something else. Oh, okay. You want me to talk slowly? Okay, I'll talk slower. I'm sorry. I know I talk a bit fast. My bad. I'll do it again then. Just so that it's clear for you guys. So you have the spinothalamic tract, okay? Main thing you have to know about the spinothalamic tract has the pain, temperature, and crude touch. And then again, all sensory tracts, but two, they're all taking, they'll be all using three neurons, okay? While the motor is going to be using two. We'll get to that. Now, you're going to take your information from the spinal root, okay? From here, it's going to go towards the cord, and it's going to synapse here, okay? And it's going to change sides, and it's going to go all the way up. It goes all the way up to the thalamus. It's some place called VPL thalamus, okay? And then from the thalamus, it goes to the cortex, okay? That's your, so first, second, and then third, cool? That's three neurons. One here, there's one, there's the whole long one, and then there's the one, okay? And the main thing you have to know is that it crosses at the spinal level of the spinal cord, okay? So most of the lesions are going to be contralateral. That's when the questions come. It usually just realize that it's on the contralateral side in spinothalamic tract. That's one thing you have to know. Now going on to the posterior column, you have again, it's going to be three neurons. Okay, the first, the second, and the third degree, and they collect information from the pacinian and the myoclonic corpuscles. Okay, and they are not going to cross at the level of the spinal cord. They cross at the level of lower medulla. Okay. And from the lower medulla, they go all the way to the VPL at the thalamus, and then from there to the cortex, okay? What you have to know is that the second neuron, you have nucleus cuneatus and nucleus gracilis. So basically, it goes from the spinal cord, it goes all the way up, and then they all combine into one big pile, and they go all the way up, right? So it's nucleus gracilis and cuneatus are the ones that are receiving it. And nucleus cuneatus is for the upper body, while the gracilis is for the lower body. An easy way of remembering this, as I said, was gracilis has an L in it, so it's lower body. Cuneatus has a U in it, so it's for the upper body. And it will go up VPL thalamus, and then from VPL thalamus, it will go all the way to the cortex, okay? Another question or something. Okay, so the motor thing, I'll explain it to you right now because, okay, look, it's by motor, I'll explain it to you. You'll see in the picture, you'll understand. You understand. What was the other question? At the level of the spinal cord, would it be ipsilateral? Which one would be ipsilateral? The posterior column, you mean, or do you mean the spinothalamic tract? And at the level, yes, it would be ipsilateral because if there's a damage, if there's like Syringomyelia or whatever the disease is, it's going to be bilateral. So let's say you have any damage to the spinal cord at this level, right? It's going to be bilateral. If you cut off the whole spinal cord, if there's a damage to this whole section, it would be bilateral. So that's one thing. But if it's a hemisection, then it's ipsilateral below the level of the lesion. At the level of the lesion, it's ipsilateral. Does that make sense? What do you mean by two motor? Okay, that'll explain when it comes to spinothalamic tract. Okay, the spinothalamic tract. Okay, so below the level of the lesion, it will be below the level of the lesion, it's going to be contralateral. At the level of the lesion, it's ipsilateral. Does that make sense? I don't know if that makes sense or not. Does that make sense to you? Or am I just spewing something wrong? Okay, I'm gonna guess that makes sense. Okay, and there's two neurons. I'll explain to you right now for the corticospinal tract. Look, at the corticospinal tract, you have two neurons. Why? So the corticospinal tract, you have to understand, is that you have the upper motor neuron and you have the lower motor neurons. Okay, and the main job is the neurons that are coming from the top. Their job is to basically inhibit. Okay, that's one thing you have to understand. It's an inhibitory supply of neurons that are coming from above. So from the cortex all the way to the anterior horn, main function is inhibition. Okay, so this is what they mean by two neurons. Okay, the first and the second. So it comes from the cortex all the way down until here, and then there's a synapse, and then it goes. Synapse is where in the anterior horn, and from the anterior horn it will go to the muscle, and the decussation happens at the lower medulla. So it changes sides at the lower medulla, and then it comes to the spinal cord, goes to the anterior horn, and from the anterior horn it synapses, and then it goes to the muscle and whatnot. So these are the two neurons. I hope that makes sense. Okay. From medial lemniscus at the level of medulla. Medial lemniscus is, yes, the medial lemniscus is decussating at the level of the lower medulla. Okay, that's what's happening in medial lemniscus. I'm sorry, I'm going back and forth, but that was the question. Okay, so the only one that changes sides at the level of the spinal cord is the spinothalamic tract. The rest, both of them, are in the medulla. Okay, that's what you have to know. Both of them will be in the medulla, the posterior column, and your corticospinal tract. Only spinothalamic tract is the one that is changing sides at the level of the spinal cord. Okay, and the sensory, both of the sensories, they have three neurons. Okay, it's going to be three levels, three synapses. Okay, so three neurons. The first one is going to be from the spinal root to the cord, then the one that goes from the spinal cord all the way to the VPL at the thalamus, and then from there to the cortex. Okay, the only difference between the spinothalamic tract and the other one, posterior column, is that one switches down to the spinothalamic tract, one switches down at the spinal cord, while the other one switches at the lower medulla. Okay, it switches here. And then you have the nucleus cutaneous and gracilis, and one's lower, one's upper. How can you tell one has U, one has L? And this is your corticospinal tract. And this, again, I'll explain it. It's coming from the top, it's coming all the way down, and it goes to the anterior horn, and from the anterior horn, it goes towards the muscle. Okay, and that's why it's two. And from the top coming down, it's giving you inhibitory supply. Okay, and then so that means the lower motor neurons are the ones that are excitatory neurons. Okay, so what does that mean? Anytime there's an upper motor neuron lesion, what does that mean? You're losing the inhibitory supply. So there's no inhibition happening. Okay, because there's no inhibition, that means you'll have it will be too much excitation. So it'll be spasticity. Okay, so you'll see the clonus, you'll see the reflexes going wild, all that stuff. Why? Because the upper motor neuron is gone. Well, in the lower motor neuron, it's the opposite. Okay, so if you damage the lower motor neuron because it's the excitatory neuron, what's going to happen? It's going to cause a flaccid type of effect. It's going to be flaccid paralysis and all sorts of stuff, right? And what you have to know is the lower motor neuron, most of the time or always, the lesions will be in the green matter, okay? Because it's going from there. So the anterior horn is the one that will be causing the lower motor neurons to go out, right? So that's where the lower motor neurons are. While the upper motor neurons lesions will be in the white matter. So anytime there's a lesion, let's say someone's like a lesion in the corticospinal tract or in the white matter, that will be the upper motor neuron. The lower motor neuron lesions will be in the gray matter. Okay, does that make sense? Can you give an example in the CT if there's a lesion? Yes. Can you give an example in the CT if there's a lesion? I don't know what that means. Can you repeat the question, or in the cortical, in the seal? Okay. I'm waiting for you to write the question. Okay, the corticospinal tract. If there's a lesion in the corticospinal tract. Okay, so okay, so let's just say there's damage in the corticospinal tract. Let's say in one of the diseases, there's different types of disease, right? We'll talk about them. Let's say a knife wound or anything, knife wound, any sort of injury below the level or whatever, right? You have okay, so you have an injury. Now, if the injury or whatever damage or lesion, it's only affecting the if it affects the white matter, which is this part. Do I have a better picture? But this part, okay. Then you have upper motor neuron lesions, and you'll have spastic type of paralysis. Well, if it affects the gray matter over here, it's going to cause more type of flaccid type of paralysis. And the lesions, you will talk about it next in the next lecture right now. It's because this lecture, there's not much left anyways. These are the three main things I wanted to talk about in this lecture anyways. But the lesions, we'll talk about them more in the other lecture. But I hope you understand that if there's a lesion, it can affect either the lower motor neuron or the upper motor neuron. And the upper motor neuron is just going to give you a spastic type of paralysis. The lower motor neuron will give you a flaccid type of paralysis. And all of this, both type of lesions will give you weakness. So generalized weakness will be in both of them, but one will be flaccid, one will be spastic. And the lesions, we'll talk about them in literally like 5 minutes. I'll go over a lot of lesions right now. Lastly, you have key points, just a bunch of key points I'd like to go over before we go into the lesions lecture, is that you have the anterior horn, which has the motor nerves. Okay, so your anterior horn is over here. Okay, this is where your lower motor neurons are going from. So from here, from the top, all the neurons are going to come here, and it's going to go from here this way, all that. So if you have a lesion here, it's going to cause lower motor neuron lesions. Okay, then you have the posterior horn, which is your sensory nerves right here, pain and temperature and everything. Okay, your lateral horn, it's autonomic nerves or sympathetic and everything, can lead to a Horner syndrome, and usually in the thoracic. You have your spinothalamic tract, which would be over here, which is your pain and temperature. You have your medial lemniscus tract, your dorsal tract, which is at the back here, and causes vibration proprioception. You have your corticospinal tract, which is out here, which causes which is for your, for your motor function and everything, and damage to this causes upper motor neuron lesions. Okay. That's it for this lecture. There's nothing much else is there, because continuation is just basically explaining all this to you in just a longer format. So if you have any questions about this, we can go over them right now, and then I can move on to the lesions if no one has questions in regards to this lecture. And I know this was a very quick explanation, but I don't, because the thing is, if I go over every single slide, that's like 70 slides, it's not going to finish in an hour. I'm guessing there's no questions, so I can move on to the next lecture, which is the lesions lecture. And this is the most, this is the easier, sorry, this is the, if you understand this part, the previous part, these lesions are going to be very simple for you. They're not going to be very difficult, okay? And a lot of the exams is going to be just a bunch of lesions. He's not going to ask you about the anatomy and anything from the first lecture. Most of the time, he just asks you 1 or 2 questions about random stuff that's in the lecture, like, which thoracic vertebra and so on and so forth. But other than that, he's just going to mostly ask you about the spinal cord lesions, okay? So you can have different types of paralysis. You have the monoplegia, the diplegia, the paraplegia, hemiplegia, and quadriplegia. You can just read this. This is not that deep or anything. Now, okay, so first of all, the first lesion, the first type of syndrome we're going to talk about is the spinal shock syndrome, okay? And it's basically when there's severe and acute damage. So one thing is, it's not going to be a chronic thing. It's going to be very quick. Someone came in a car crash, something happened to someone, it's knife wound, some sort of big thing happens. It's not going to be something that's going to be developing, okay? So that's one thing. The other thing is, he'll, at the level, or below the level lesion, he'll lose most of his functions, and he's going to lose all sorts of sensory, and it become flaccid paralysis, okay, to the person. And the test for this, and how they figure out if this person has a spinal shock syndrome, is usually the anal reflex, okay? And the reflex is basically the anal canal basically try to stimulate the anal sphincter and see if it will contract or not, That's it, basically. So the reflex can be initiated by, basically, as he says here, placing a glove finger in the anal canal, stimulating the anal sphincter to contract by squeezing the glans penis or the clitoris, gently tugging on the inserted Foley's catheter. Okay, so basically you're trying to see if the anal sphincter will contract on the finger. This is just to see if the person has it or not. So if there's no anal reflex, that means he has no ability below the level of lesion. Okay, so this means the person is in spinal shock. And usually these people recover in 24 hours, but it may last longer depending on what is affected. Maybe his respiratory is affected. Like, depends. A lot of things could be affected. So depending on that, okay. Again, this is a very general syndrome. So this is, again, not. I don't think this will be in your exam again. I think the others are more likely to come in your exam, like complete cord syndrome and the tabes dorsalis and the other stuff, and we'll talk about that right now. So the next one is complete cord transection syndrome. Okay, so now here we can explain all the lesions to you guys. Okay, so now you have a transection of your complete cord. Okay, so now look at this cord. Okay, you have your gray matter here, you have your white matter here. Okay, so this is your dorsal, you have your anterior, your lateral, you have your dorsal column, you have your anterior spinal cortical columns, and you have these spinothalamic columns here. Okay, now when you damage this at this level, right? At this level, what's happening is that you are damaging all the sensory. Okay, you damage all the sensory at this level. So there's going to be no sensation at the level. I'm talking about at the level. So all the sensations are going to be gone. And also at the level, you're going to be damaging the anterior horn also. Okay, you are obviously damaging everything at this level, and you're going to be damaging the anterior horn. That's why you will have lower motor neuron paralysis at the level of the lesion. Okay, and below it, because you're not damaging below it, the anterior horn is not being damaged. Below it, what's going to be damaged is the nerves that will be going on this. So at the white matter, the nerves that will be going down, all the nerves that are going down here, because it's been cut at this level, right? So the nerves that will be going down will be the ones that will be damaged. Okay, so below it, that's why you will have spastic paralysis. But at the level, because you're damaging everything here, and you'll be damaging the anterior horn also, that's why you will have lower motor neuron paralysis. But below it, you will have spastic paralysis because the nerves that are going down, the ones at the white matter, have been cut at this level. Okay, so there are no nerves that are going down. Okay, so all of them below it will have spastic type of paralysis. Why? Because the upper motor neuron upper motor neuron has been damaged, leading to what? No inhibition. So that means the lower motor neurons below the level of the lesion will start to spasm. Does that make sense? And below the lower of the lesion, also all sensations below the level of the lesion will also be lost. Okay. And so as he says, the loss of tactile discrimination, vibratory, proprioceptive sensations, bilateral discrimination, pain, temperature sensations at lateral, spinothalamic tracts on both sides, because I'll explain to you, because both sides, because you cut it on both sides. Okay, so this is not like it's half and half and whatnot. So all sensations will be damaged at all levels. Okay, and the main difference and the main thing you have to keep in mind that the only thing that's difficult in this one is the kind of small trick is that the lower motor neuron at the level, or below the level, it's all spastic type of paralysis. I hope this one makes sense. If you can you explain the last sentence correctly? Nullify. Okay, sure. Bladder, last sentence. Where's the nullify one? You see bladder, volunteer control. Wait, is it in this one? Or are you talking about this? Okay, are you talking about the last bladder? Okay, I'm going to see last sentence. Where's the last sentence in round trash? Yeah, no, where's okay, my bad. I can't see the sentence for some reason. Where? It's in the one before. Oh, spinal shock syndrome. Okay, my bad. No, spinal shock syndrome. Okay, last sentence. A cord lesion involving the sacral segments of the cord would verify this test, since the new one is giving rise to a cord lesion involving the sacral segments. So a cord lesion involving the sacral segments would nullify this test, since the new one is giving rise to the inferior hemorrhageal nerves and sphincter would be non-functional. Okay, so what they're basically saying is that if there's a lesion at the sacrum ligament, right? So sacral ligament, sacral segments. So usually it's called the cauda equina syndrome or anything. the test will not be, and there's no point in doing the test. Basically, it nullifies the test because the neurons that give rise to the anal sphincter and whatnot will not be functioning. Okay, so the test doesn't matter at that point because they're not functioning. But over here in spinal shock syndrome, it's not that the neurons are not functioning, but it's the neurons in this level over here. Okay, they'll be non-functioning. Here, they're also not functioning, but they'll start to function again. That's what the point is, because here you're cutting off at the level. So cord lesion sacral segments, you're cutting them off. So you're damaging the neurons. So they won't be working here. They might work again after 24 hours, after 4 or 5 weeks, the person regains because the shock is gone. So this is because of the shock. This is because you're getting the lesion at the segment. You understand? That's the difference. Over here, the person went into shock. So he's going to be hypertensive. You might lose a lot of things. And spinal shock is different than getting a lesion. You understand that? Okay. You're welcome. Do you guys understand the complete cord transection syndrome? I explained it. Do you guys understand the difference between the one that's going to be the spastic paralysis and okay. Okay, so I'll move on. I'll go to the next one. Okay, everyone understands that one. Okay. Brown-Séquard syndrome. So if you guys understand these syndromes, trust me, there's going to be no issue in the exam for you guys, because if you understand the syndromes, that means you understand the tracts perfectly. Now, Brown-Séquard syndrome is basically hemisection of the spinal cord is getting affected. Okay, so when you are cutting the hemisection, okay, so at the level of the lesion, okay, first of all sensations are being lost. Okay, at the level of the lesion. Okay, because let's say the stuff that's coming from the Spinothalamic Tract over here, it can't cross. So you're all sensation. So, and you're losing the Spinothalamic Tract on this side, and also on this side, because on the right side you're losing it because it got cut here. Okay, you're losing the dorsal tract. Okay, you're losing all sensations basically at the level of the lesion. I hope that completely makes sense. Okay, and sorry, I meant on the ipsilateral side, not on the left side. That's my bad. I was thinking about the previous syndrome. At the ipsilateral side, using all sensations, okay? The spinothalamic tract can't cross, and the dorsal tract, it can't go up, and you're losing sensations on that side. The will be lower on the, you'll have lower motor neuron lesions on this side also. Why? And it will be ipsilateral. Why? Again, because you're damaging the anterior horn again, okay? So the anterior horn will be damaged, leading to lower motor neuron signs at the level of lesion. Okay, again, that's it. At the level of lesion, so you have ipsilateral loss of all sensations, ipsilateral lower motor neuron signs. Okay, now below it, again, it's literally like if you understand the previous syndrome, you understand this. It's just half. That's basically it. So below it, it will be upper motor neuron signs. Because why? Because you're damaging this part of it. Because the nerves that are supposed to go down, they will be damaged. Okay, the anterior horn below the level of lesion is fine. The only thing is the nerves have been cut, so they will lead to upper motor neuron lesions below the level of lesion, which will be spastic paralysis and all that sort of things. Okay, and then you have ipsilateral loss of proprioception, vibration, and light, touch, light and touch and all that. So basically, the dorsal column, ipsilateral, again, below the level of lesion. Why? Because dorsal column is here, it's going down. Okay, so it will be ipsilateral. It's going down, so you're cutting the nerve, so below it, everything is also cut. Okay, does that make sense? Below it, everything's also affected. I hope that makes sense. The only issue is the contralateral loss of pain and temperature. Okay, below the level of lesion, it will be contralateral. Why? Because the ones from below are crossing over. Okay, so if you cut it on this side, that means they're coming from here. You see the marker. So if it's cut at the right side, that means they're coming from the left side also. They're coming from the left side, they cross and they go up, right? So if you cut it here, that means these ones, you're going to lose on this side. Because the one from the right side also is crossing over and going to the left side. The left side is not affected. Okay, so I'll say it all again, and I hope this one makes sense, because this is the most difficult ones. If you understand this, then the rest of them are very easy, and you understand the previous lecture completely. You don't need to go over the 70 slides. You don't need to go. So in total, these are 100 slides. Again, I don't know why there's 100 slides, but yeah. So at Brown-Séquard syndrome, most of the times, okay, you have ipsilateral loss of all sensations at the level of the lesion. Okay, why? Because you're damaging dorsal, you're damaging your spinothalamic. You'll have nothing at this level, no sensations. And you have lower motor neuron lesion. Why? Because the anterior horn is affected. So nothing. Yeah, the anterior horn is affected. No excitations happen. Okay, no excitation to the neurons. Okay, so no more. So it's going to be flaccid paralysis. Then below the level of the lesion, you're going to have upper motor neurons. Why? Because the neurons have been cut. The nerves have been cut at this level, so they're not going down. Okay, because the anterior horn below the level of the lesion are perfectly fine. What is not fine below the level of the lesion are the nerves. So we'll have ipsilateral upper motor neuron signs below the level of the lesion. And you'll also have ipsilateral, loss of proprioception, loss of vibration, and two-touch discrimination and whatnot. Below the level of the lesion, it will be ipsilateral. Why? Because dorsal column is affected, and dorsal column is just the nerves are going down. Okay, and it will be contralateral loss of pain and temperature. Why? Because spinothalamic tract. Okay, and spinothalamic tract for the right one is coming from the left side because they switch, as we said, they switch at the level of the spinal cord. Okay, so it's coming from here, it switches, bam, it going up. Now you cut it down, so it's going to be affecting this part. Okay, for the right one, it will be on the left side, so it's not going to be affected. Okay. And another thing that's important, and they might just slide this in at some point, and you might get confused, why not, is anytime, as I mentioned, thoracic has what? It has the lateral horn also, like with this one right here. And anytime it's used, if the lesion occurs above T1, the patient may present with ipsilateral horn syndrome, okay? So always remember, usually the lesions in happen in the thoracic level or above the thoracic level, they usually will present with, Horner syndrome if they are affecting the lateral area, basically lateral horn. Okay, remember that. That's something to keep in the back of your head. Don't forget that. Okay, I'm going to see if you guys have any questions for this one. What about CT below the level of the spinal cord? Okay, so the cortical spinal tract below the level of the cortical spinal tract below the level of the spinal cord, below the level, as I said, it's going to be affected. That's why the cortical spinal tract, when it is affected below the level of the lesion, okay, understand this. You cut something at this level, okay? Just imagine in your head, you're cutting something, okay? You cut it at this level, okay? These ones, okay, the fibers are not going down because even if they are going down, it's not attached, right? It's not attached here because I cut it at this point, the fibers, the corticospinal tract, it's not going down. It's not going to be going down because they're not attached. It will be going down, but there's no connection between them. So there's no messages or nothing is being passed down, okay? So have that in your mind, okay? So if the cortical spinal tract has been cut, okay, what's going to happen? You're going to be losing what? You're going to be losing your motor sensations, right? So that's why it is upper motor neuron below the level of the lesion because you cut the cortical spinal tract at the level, you cut it here. So below it, you're going to be affected with all upper motor neurons. But at the level of the lesion, you have affected the anterior horn. Okay, and anterior horn is going to cause what? Your lower motor neuron signs. But below the level of the lesion, none of the anterior horns are affected. Okay, all the ones the only thing that's affected below the level is the cortical spinal tract. That's why you're affecting that's why you have the upper motor neuron lesion. Does that make sense? Let me know if that makes sense. If it doesn't make sense, I will repeat it. But does that make sense? Yes or no? So we can move on to the next one. Okay, I'm guessing that makes sense because no one's replying back. Okay. All right, cool. So Brown-Séquard syndrome, the classic presentation is going to be someone that comes in with it's usually someone gets stabbed in the back or something like that, okay? At the level of lesion, we said there's going to be no sensation, okay? On the side that the person got stabbed, he's going to have what? Upper motor neuron signs, okay, as we said. Okay, on the side you got stabbed below the level of the lesion. You're going to have spastic paralysis, Babinski sign, and you're going to have loss of vibration and proprioception. On the other side, contralateral loss of pain and temperature. Okay, this is a classic presentation. Now you have your anterior cord syndrome. Basically, anterior cord syndrome, because of the spinal artery. So you have the anterior side is mainly supplied by your anterior spinal artery, while the posterior side is supplied by the posterior spinal artery. So now if you take away the anterior spinal artery, what's going to happen is that the complete anterior side is damaged, and everything other than the dorsal column is damaged, okay? So what's going to happen? Again, it's basically the same thing. So below the level of the lesion, what are you going to be affected with? You're going to be affected with it's going to be an upper motor neuron type of paralysis below the level, okay? Because your corticospinal tract has been affected, okay? But at the level, you're going to see lower motor neuron signs, okay? And I hope this makes sense, because if you understand the previous one, all the next ones with any lower motor, upper motor neurons, all that makes sense, okay? So at the level, you have lower motor neuron lesions, okay? And below the lower, you have upper motor neuron deficit, okay? And you'll have no loss of, crude touch and proprioception and that two-point discrimination, all that vibration. Why? Because dorsal column is intact. Only thing you're going to lose is going to be what? Loss of pain, temperature, and sensation below the level of the lesion. Okay, does that make sense? complete occlusion of the anterior spinal artery. And the way they can ask you this question is going to be like, oh, usually in aortic aneurysm repair or like some sort of surgery they were doing and this happened. Okay, does that make sense? Because I think the rest of the lesions are pretty simple. Okay, because you understand the first big two, because this is the main one that tricks everyone. Brown-Séquard the question that tricks, or the lesion that tricks everyone, and they trick everyone with. Okay, now your central cord syndrome is basically Syringomyelia. Okay, what is this? Basically in the middle, where the anterior white commissioner is, it's compressed by a syrinx. A syrinx is any sort of like a cyst. Okay, so something like this. Basically, you can see it here. It just forms and it's expanding. Okay, and it's like a type of a cyst. So what happens is that what will be affected? Okay, the thing that will be affected if it's a small cyst. Okay, so start off with something small. If it's small, the thing that's going to be affected is the spinothalamic tract, because this is the tract that goes and it switches, right? So it goes to the middle and it switches to the other side. Okay, so if a person has Syringomyelia, so what's going to happen is that, and it usually, by the way, happens at the level around C8 to T1, somewhere around that, right? So basically what's going to happen, C5, C4, as they say, C5 to T4, as they say, it's going to give you like a cape-like distribution, what they mean. So what that means is that bilaterally, and it's going to be bilateral. Why? Because you can't come from this way. So from the person from the right side can't switch to the left, the nerves, and from the left can't switch to the right. Okay, so it's going to be bilateral, and it's going to be cape-like distribution and it's going to be on both sides, and you won't be able to feel your loss. It's going to be loss of pain and temperature sensations, and then the affected dermatomes. Okay, now this is if it's small. If it increases in size, okay, if it becomes bigger, what can happen? It can affect your interior part also. It can affect your anterior horn also. Okay, and if it gets even bigger, it can affect your ventral horn. So keep that in mind, is that a small Syringomyelia usually is going to just present with what? Cape-like syndrome. Okay, it's going to be cape-like and it's going to be bilateral. And yeah, if it gets bigger and if it's a bigger cyst, whatnot, it can affect your anterior horn and it can also affect your lateral. Okay, and present with Horner syndrome and lower motor neuron paralysis. Okay, and they're associated with carrier malformations and scoliosis. So something to remember that is carrier malformations. I don't think that they're going to present, or they will present, but I'm saying it'll be kind of difficult for you to in the question. But scoliosis is something very simple. You can keep that in mind. Scoliosis can cause can lead to Syringomyelia. Also, trauma or tumors in the back can also later in the future can lead to this. Okay, so the classic presentation is going to be a person who can't feel. So it's going to have cuts and burns on hands they're not feeling because they can't feel the pain and temperature. Okay, and they'll have loss of pinprick and temperature on the back of their shoulders and arms. Okay, and again, they can also present with motor weakness or Horner syndrome. No questions, so I'm guessing you guys understand what I'm talking about. Okay, so again, see, if you guys are understanding this, that means the previous lecture you guys understood. So again, I'm repeating this to you. If you understand the lesions, that means you don't have to go over all these slides and all this and everything, because the questions are just going to come from the lesions. And I repeat this because I remember when I was in second year, I had to go over these slides and blah, 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 and do all this. And at the end of the day, you only, and especially Dr. Latin, he only asked, and he keeps up, and mostly it's always steps related questions, really, okay? Usually everything related to the board, everything related to clinical scenarios, not like most of the other doctors, because some of the other doctors will bring you questions that are not related to clinical stuff. It's just going to be anything, what's at T1, what nerves are coming out, something like that, right? He's going to ask you clinical related questions. That's why I'm focusing more on the lesions lecture, okay? Now you have spinal muscular atrophy. This syndrome and the next one, they're quite similar, okay? So this is Wernicke-Hoffmann's disease, okay? And basically what's happening is that you have anterior horns affected, okay? So this is congenital degeneration of your anterior horn. So again, we've talked about this multiple times. What's it going to do? It's going to affect the anterior horn. It's going to cause lower motor neuron type of symptoms symmetrically, okay? And it's going to cause what flaccid type of paralysis, and they present with tongue fasciculation. So this is something, try to remember this. And it usually happens with kids, and it's going to be a floppy baby. And tongue fasciculations, remember this because it's a weird type of thing for, usually don't present with tongue fasciculations. There's no such thing, okay? So keep that in mind, okay? Wernicke-Hoffmann's disease and ALS, okay? So ALS is also kind of similar, but the only difference is ALS has both upper and motor. Now, this is perfectly, and it's a perfect example for you to remember what the difference is between upper and motor. Over here, they're only affected the anterior horn. Over here, it affects both the anterior horn and the tract. Now we have upper motor neuron type of lesions as well, okay? So the person who was asking, what about the corticospinal tract and everything, you can see, once it affects the corticospinal tract, so it's going to cause upper motor neuron. But if it stays here in the anterior horn, you're only going to get lower motor neuron lesions, okay? So ALS, we really don't know why this usually happens, and there's theory and whatnot. It causes it because of superoxide dismutase and whatnot. But they really don't really know why it happens. Okay, but anyways, it's caused because you have a combined upper motor neuron and lower motor neuron degeneration, and basically you have upper motor neuron type of paralysis, which is spastic paralysis. You have hyperreflexia and whatnot. Then you have flaccid paralysis also, and it will be, you have both types. Okay, the treatment, which they say riluzole, it really doesn't help the patient. It only delays it for a bit, but then at the end of the day, the patient usually dies at a younger age. Classic presentation is usually a 50-year-old patient. Okay, slowly progressive course, and you have arm weakness, you have dysphagia to solids and liquids, some flaccid muscles, some spastic muscles. Okay, and then you have no sensory symptoms. So because there's nothing related to sensory, all the sensory symptoms will be good. Okay, this makes no sense. Okay. Most of the people, in these symptoms, they usually end up dying because of respiratory problems and whatnot, dysphagia and whatnot. So that's usually the issue in people like this. Okay, tabes dorsalis. So you have, if you guys took, I don't know if you guys have taken syphilis and whatnot. So there's primary syphilis, it begins with something called the canker, and then it goes into becoming a secondary syphilis, which is like stays there for a while and nothing happens to the person. And then tertiary syphilis is this, which is a neurodegeneration type of disease. Okay, and what it affects is the dorsal columns and also affects the dorsal root. Okay. So when it affects the dorsal column, right, everything else is normal. So dorsal column is going to be affected. What's going to happen is that you're going to have, the type of sensations. So you have the proprioception, you have the crude touch, it's a crude, two-point discrimination and whatnot. So you're going to have the sensory problems, okay? And also because it's affecting the dorsal root, okay, what you're going to have is that you're going to have problems with your reflexes, okay? That's one thing to remember. So the person's going to have delayed reflexes and problems with reflexes and proprioception and whatnot. So Romberg test is a test in which you make the person close his eyes and they stretch their arms out and try to balance themselves. And people who have tabes dorsalis or any other people who have problems with proprioception, their Romberg test is going to be positive. Okay. And also, kind of the people who present with tabes dorsalis, they have something called the Argyll-Robertson pupil. It doesn't have the light reaction. I think that's what it is basically. It doesn't react to light, but then it focuses. I forgot what the exact thing was with Argyll-Robertson pupil, but yeah, basically, kind of remember the associated symptoms with tabes dorsalis. So patient classically is, he has STDs and whatnot, might even have HIV. And he finds difficulty walking. He'll have strength in his legs and arms, but he's going to have positive 5 out of 5 strength in legs and arms. Okay, he's positive Romberg, as I said. Wide-based gait, again, because he has no proprioception. Difficulty, fleeting, recurrent shooting pains. This is because of the associated symptoms. You have Charcot joints and shooting pains. Again, this presents with this disease. Loss of ankle and knee reflexes because it's affecting the dorsal roots. Okay. And you have Argyll-Robertson pupils. Okay. Again, look at the questions. If anyone has questions, no one has questions. Okay. Oh, why is there sudden shooting pains? Okay, so it's got nothing to do with the columns and whatnot. It's just, yeah, it's a random part of the disease. Even I didn't look it up much, but I know that it's got nothing to do with the whole thing. So it's just also an association of the disease that person gets random shooting pains. Same thing goes for the Argyll-Robertson and also the Charcot joints. It's not really that sort of thing. Maybe it's got something to do with the fact that he has tertiary syphilis and it's really painful. I don't know, but it's not really related to the spinal cord and whatnot. So don't worry, they're never gonna ask you that. Oh yeah. Vitamin B12. Okay, so if you see this one, it's basically tabes dorsalis. Okay, vitamin B12 deficiency is tabes dorsalis, and you just add a corticospinal tract. That's basically it. Okay, so a person with vitamin B12 deficiency, it's called subacute combined degeneration. Okay, and the tracts that are affected are your corticospinal tract, your dorsal column tract, and your spinocerebellar tract. I know I didn't talk about the spinocerebellar tract, but again, it's not going to come in your exam. I doubt they will bring a question. And spinocerebellar tract is mainly to do with, again, your proprioception, okay, the unconscious proprioception. So again, what's going to be affected in this person is going to be upper motor neuron signs because corticospinal tracts are affected, okay, and he's going to have ataxic gait. He's going to have he's not going to have any proprioception, vibration, sensations, and all that. And again, it's going to be a positive Romberg sign. Classic presentation is going to have problem walking, positive Romberg, spastic paralysis in his legs. Why? Because upper motor neurons are affected. Positive Babinski and hyperreflexia again. While in the other person, he had no reflexes. This person has reflexes. You get a difference, okay? You have your quadra equina syndrome, okay? And quadra equina, again, so basically the spinal cord in adults usually ends around L1, L2. And then you have your conus medullaris, which is the end of the spinal cord. And then below it, then you have the quadra equina, which is basically what they call is the horse tail or whatnot. It's just a bunch of the spinal nerves are going out all the way, right? So if there's a compression of the spinal cord over here, they say L2 and below. Any usually can happen. It could be any reason. Again, they see disc herniation and whatnot. You have lower motor neuron type of. It's going to present like lower motor neuron type. Okay, and why is it lower motor neuron type? Because it's no longer in the spinal cord. That's why. Okay, understand that. It's no longer in the spinal cord. Okay, so you're gonna have a lower motor neuron type of. So that's why it's absent knee, absent ankle, reflexes, loss of bladder, anal sphincter, loss of saddle anesthesia and whatnot. So the main thing is he's gonna have type of a lower motor neuron lesion because he's no longer in the spinal cord, so the upper motor neurons aren't coming down. You get me? I hope that makes sense. That kind of. Oh, the Argo-Robertson isn't okay. So Argo-Robertson pupil isn't shining in the eye light thing. Okay, it's basically you do a test. It's a type of a pupil. Okay, and it means that when they shine light, it doesn't work in one eye, but then the other eye can follow through or something whatnot. You can look that up on your own time. I don't remember the exact thing, but it's just a type of a feature. Like this isn't related to. It's not related to spinal cord and whatnot. It's just type of a feature that happens with it. I don't remember exactly what happened because I took ophthalmology like what two years ago. Yeah, and yeah, I don't really remember exactly what the Argo-Robertson is, but yeah. Anyways, we're back to the quadra equina syndrome. So just realize if there is, this is better. I think there was a better picture of. I didn't put a picture for quadra equina. That's disappointing. Okay, so I think I have a picture. 1 second. Let me see. There's a picture. I'll just add it quickly. Insert photos. Okay, it's okay. My bad. Let me just. Let's do it this way. Anyways, all right. So if you can see here, you'll have like saddle type of anesthesia. Okay, just remember that saddle type of anesthesia. Okay, so it's going to present like this. You have low back pain because you're affecting low back. Usually happens with the disc and whatnot. Okay, and you have the anocutaneous reflexes. The one we talked about in the beginning will be affected because you are affecting literally the nerves that are causing the reflux. Bladder dysfunction again because the nerves there are controlling this. And then you have normal Babinski, and you're going to lose your absent. The reflexes will be also absent. Okay, your reflexes, and you're going to have a type of lower motor neuron paralysis because you're not. The upper motor neurons are no longer there. You're no longer in the spinal cord. That's why. Okay. I think this is the last one. Poliomyelitis. Okay, so poliomyelitis is a virus, and this used to. If anyone's from Pakistan here, they would know that they still happen in Pakistan, but most of the world doesn't have any polio. Anyway, so it's caused by the poliovirus, and it causes destruction of the anterior horn of the spinal cord. And at this point, if anything that is damaged the anterior horn, it will lead to lower motor neuron lesions. Okay, and it's an asymmetric type of lesion. Okay, again, flaccid paralysis, hypotonia, fasciculations, hyperreflexia, muscle atrophy, and whatnot, and all types of any type of lesion in the motor neurons will cause weakness in general. So you have weakness in both. Remember that also. Also present with signs of infection. That's something different. So you don't have that in the other problems. You don't have the signs of infection in anything else except in this. Again, the other difference is going to be CSF. So, WBCs, slight protein, and all this. Why? Because, again, you have an infection. So WBCs will be high, protein will also be changing. So all this is, again, just to help you out to diagnose someone who has polio. Okay. So again, realize anything that affects the anterior horn, lower motor neuron. Upper motor neuron will be the corticospinal tract, and dorsal is pretty simple. And the spinothalamic tract, if it's below the level, it's going to be on the other side because that's how it crosses. It crosses at the level of the spinothalamic tract. I think the polio usually presentation will be like a kid that's unvaccinated, so they will give you a child that's coming from, let's say, a different country, let's say the Middle East or somewhere else, they present to you at the clinic and you don't have their vaccination records, okay, and whatnot. That's how they usually say it. And he's kind of ill for the last 5 days. He's trying to have weakness, and it's, stronger in the legs than the arms and whatnot. And it's going to be kind of flaccid type of thing. So it's polio, okay? So yeah, that's how you get your question about polio. Again, lastly, Friedreich's ataxia. Actually, they didn't teach us this when we were back in neuro. I'm surprised they put this in for you guys. But anyways, the degeneration at this, you can see in the picture here, you have dorsal columns are affected, okay? So vibratory sensing and proprioception and dot, all that is affected, okay? And then dorsal root ganglia is affected, so you're going to lose all your reflexes. And your corticospinal tract is affected. So again, what's going to happen? Spastic type of paralysis. Also, the person has ataxia because you're also spinocerebral tract is also affected. So he has ataxia. So this person is going to present with ataxia. He's going to have spastic paralysis, loss of sensations, whatnot. And yeah, that's basically it. And this patient presents with a lot of things, as they say here, stagnant gait. Again, that's basically because he has ataxia, so he's going to have a stagnant gait. Frequent falling, again, because it doesn't have his proprioception, diabetes mellitus, hypertrophic cardiomyopathy. All these other things are not related to because of the spinal cord and whatnot. These are because of his gene disorder, because it's a whole different disorder, okay? So yeah, that's basically it on spinal cord and spinal lesions. I know I went very quickly over the spinal cord, but because I wanted to come over to the lesions, because I thought if you guys have a basic idea of the spinal cord and you look over the lesions, all of it's going to make sense. And if you understand this part and you were like, oh, I'm kind of confused in the beginning, but if you actually understand this part, then it means you completely understand, and I'd focus on something else for your exam. Does anyone have any questions? You're welcome. Yeah, I'll just give you a quick, I'll just review everything really quickly, just one last time. So again, just remember, and again, I focus mainly on the questions because again, that's what's basically what's important for you right now for the questions in your exams, because your exam's very soon. It's I don't know how many days, I don't know when your exam is, unfortunately. Maybe it's on Thursday, maybe it's on Sunday, whatever. Just remember, upper motor neuron is coming because it's giving inhibition. So from the top, if you have a upper motor neurons affected, okay, you're going to have what? It's going to go wild. The lower motor neuron is going to go wild. A lot of spasms. Lower motor neuron affected. It's going to cause flaccid type of paralysis because there's no excitation. The difference will be in the anterior horn. The anterior horn, and difference is going to be in the corticospinal tract. That's the one that's the most tricky. Dorsal column is pretty simple. The proprioception and whatnot is affected, vibration and everything. Spinothalamic tract. It crosses over at the level of the spinal cord, so it goes to the other side. So that means if anything gets cut above it, it's going to be on the other side. What's it called? The contralateral side, not the ipsilateral side. The contralateral side would be the one that's affected. So my advice to you would be, if you can understand this Brown-Séquard syndrome, you will understand all of the other ones, okay? Because this is the only one that's genuinely tricky, okay? And once you understand this, all the other syndromes will be very, very easy for you. So then the only thing you have to understand is the small details, like what kind of arteries affected in the anterior cord. I think anterior cord syndrome, a complete occlusion. Okay, so you kind of remember the Adams-Quish artery. Okay, that supplies below T8. That's the remember this type of stuff. So if you understand the rest of the stuff, then you're good. Okay, I hope everyone understood that, and I hope the lecture was clear. If you have any questions, you can ask Talal. He will send it to me directly. I'm sorry if I went over stuff a bit quickly because I knew the lesions would take time. So I was like, if they understand the lesions, they'll understand everything else. I guess that's the end of the lecture. If you guys have any other questions, you can direct them to Talal, or you can email me. You can find my name, Hassan Shah. You can just email me directly, Alfaisal, or just let Talal know and let me know. All right. Thank you so much, and you're welcome. I hope you guys have a good day.